it is now time for questions, and I'll just go to the first question that I have that will go to Dr. Eva. Is Eva with me? Eva, is she with us at the moment? Eva Kabongera? Perhaps I don't see her on the screen, so I'll ask a similar question that I think for Razel Bagarov and for Luis Eugenio de Souza, and that is the issue of cold chain. I was watching those pictures from Dr. Eva where we could see people carrying the vaccines in clearly refrigerated style boxes. However, of course, vaccines are vulnerable to this, and I wonder how much effort is put in let's start with the Pacific, with Samoa.
Thank you, Dr. Mura. Yes, I think this is very, very important question because, as I mentioned earlier, that when this adverse event happened in Samoa in 2018, the initial reaction was probably something wrong with the vaccine itself. Maybe the way it was stored, maybe it was not under the condition, not in the condition that it's supposed to be, and something particularly went wrong. So it is absolutely important to make sure that the storage, and of course UNICEF is our sister agency, which help the governments to maintain the cold chain. But it's important to make sure that the vaccines are really stored in under a proper temperature. There is a special mechanism to know where the temperature maintained this indicator, on the vaccines. So when before a vaccine is used, it's important to make sure. So in Samoa, with an investigation which happened, particularly in this particular case, it was clearly showing that storage was not faulty. Storage was absolutely done properly, and then we also made checks with all other district facilities where vaccines is stored. It also was in appropriate temperatures. Indeed, if you move it to the field, you need absolutely to have it in short quantities to the amount of vaccines being performed, whether you have to reach out to the remote areas. But again, in Samoa, this being done very well. Thank you.
Dr. Eva, I wonder if you can respond to that notion about cold chain and reaching those remote communities.
Yes, thank you very much. As I explained, the cold chain is one of the most important things to make sure that the vaccines reaching the child is potent. So the cold chain, as I said, we have a central vaccine store at the national level. Then from the central vaccine store to the district vaccine store, we have refrigerated trucks that take the vaccines monthly to the districts. Then from the district vaccine store, we have the health facilities, which have also smaller fridges that keep the vaccines. And from the health facilities to the communities, we have the vaccine carriers. Vaccine carriers is a small box that has ice packs in, and we pack in vaccines to make sure that the vaccines are kept properly. And one of the key things to ensure the vaccine storage is on well is the temperature monitoring. And temperature monitoring, as I showed in the effective vaccine management assessment, temperature monitoring is one of the key indicators that has to be looked at. Every health facility has to keep the temperature monitoring charts for over 3 years, so that when somebody comes for an assessment, he has to do that. So temperature monitoring is key. And then the conditioned ice packs in the vaccine carriers when they are going out to the health facility. And then there's also a sponge, so that even when you remove a vial, like those ones which have like 10 doses, you still keep it in a sponge to make sure that the temperature is actually maintained at the right acceptable levels. Thank you.
Yeah, thanks very much. We even have the same problem in developed countries. I know that sometimes general practitioners' fridges are used for things other than vaccines, and for the sandwiches for lunch and so forth, and they need monitoring, and that education needs to continue. I'm going to ask Professor De Souza about Brazil, but while you're answering that question, we also have another one, which is about the Sustainable Development Goal 3, health and wellbeing. The target for preventing U5MR by 2020. What are the with all the things happening in Brazil at the moment? What are the chances of achieving that goal by the end of 2020?
Yes, thank you. Very important question. Actually, we had a target of reducing to 0 the deaths for under 5 children for amenable causes, which would mean reducing to 25 deaths for each 1,000 babies born. In 2015, it was completely feasible, but now, considering the economic and social situation, is very difficult. If you allow me, Mike, I would share just one slide to show the forecasting we are doing. We had published this, colleagues of mine have published, David Rosella and others, published this paper in 2018. And you can see what's going on with the mortality, under 5 mortality rates with the economic crisis. And now we are in a longer economic crisis, the worst scenario. And you see in the green line, it means how even the green line with the maintenance of the conditional cash transfer and the family strategy, family health strategy, you see the slope of the curve is slowing after 2015. And in the red line, that's the austerity measures that have been taken, reducing the conditional cash transfer program and also the family health program. You see the rate of mortality continues to decline, but at a very slow pace. So if you continue in this pace, in this velocity, in this speed of decline, we will not achieve the target for 2030 in the terms of mortality rates, unfortunately. We hope things change quickly in time to be able to accelerate the decline of the mortality rate. Thank you.
Thank you, Professor De Souza. That's fantastic. I would like to address the next question. I'm going to start with Professor Ricciardi, but the question starts with a statement that the data presents an excellent picture of immunisation status in many countries. However, the outbreaks of various diseases indicate something else. So is the data presented not valid, or is a problem with vaccine effectiveness, management and administration? Where's the discrepancy? So I'll start with you, Professor Ricciardi, and I'll then go and give others an opportunity to respond as well.
No, it has to be checked where the questions come from, because in general, when you have high level of coverage, the incidence rate of vaccine preventable disease is very low, and whenever you drop below the threshold of herd immunity, this is starting to rise again. So I don't think that there is a contradiction between, of course, it can be that in some specific places you can have problem of provision, problem of storing, but it has to be checked in the very specific place. But in general, there is no correlation like this. The most is the population cover, the best is the epidemiological situation.
Rasul, would you like to respond to that? And also, we had a comment earlier that one of the problems leading to the issues in Samoa was that after the adverse incidents with those 2 babies, that some of the staff were also reluctant to immunize. So perhaps if you could also just cover that comment.
Yes, just to respond to the first one, and I also like to corroborate what Professor Ricciardi said. You know, just simple example, at the time when the Samoa experience outbreak, Tonga as well was affected, but it was affected to much less extent. And the very reason for that was that most of the population in Tonga was vaccinated, in fact, close to 99%. And another fact from Tonga was that at the time where Samoa was really struggling, and a number of cases was building up in Tonga as well, but it was mild cases, was nothing, no one died as a result of outbreak. And I guess it was just finding some pockets within this population was still maybe under immunized, but still, again, as I said, it was not to the same extent. So I very much agree, if the population is fully vaccinated, there is very little risk there. No, responding to the hesitancy on the part of the nurses, I also corroborate that one. Indeed, because I explained that it took 9 months for the vaccination ban to be lifted, and that was linked also to the court case, because at the time as the suspension was there, was still investigation was ongoing, and there was hesitancy on the part of the government as well to move on, lift the suspension because of the court case was not completed. And when the court case was completed, there was also not so explicit communication to health professionals as well, that it's very safe to continue vaccination. It's not due to vaccine, it's actually due to the human error. So yes, that's additional factor which delayed normalization of the routine vaccination and contributed to the outbreak. Thank you.
Much of our focus this evening has been around children and vaccination of children, but of course vaccination goes right across the life course, and we haven't touched on that very much at all. So if any of the others would like to answer the questions that we've just asked, but also respond to the importance of vaccination across the life course, and this will be the closing comment for each of you. So I'll go to one of you at a time, and then we're going to have to draw this webinar to a close. Dr. Eva Kabongera, thank you so much for your presentation on Uganda and answering questions. Do you have a comment around that area?
Thank you very much. Vaccination in the life course, it is something that when you look at the entire vaccination program, I can start with adolescent. The adolescents in Uganda, we just introduced the HPV, the human papillomavirus, which we are targeting the 10-year-old girls, and this they get 2 doses at 10 years of age. And also at that time, we also introduced the TD vaccination, the vaccination against tetanus. So the young girls receive that, and if we have a good program, and they can get up to at least 3 doses during their time before they get pregnant, at least the protection at birth would improve a lot. So after adolescence, we go to pregnancy. During pregnancy, the TD is one of the key vaccination that has to happen to prevent neonatal tetanus. And if a child is protected at birth, to make sure that the child is protected at birth against tetanus. So ideally they get 2 doses, but if you have been giving TD during adolescent, then during pregnancy is checking and making sure that they actually got the doses at the right time. And if there is no proof that they got the vaccines, then we give the pregnant mother at least 2 doses, 1 month apart. And of course the newborn, we have the polio 0 that is given at the birth. And then now we are discussing hepatitis B that is supposed to be introduced at birth. And then after that, we go to the infant to starting at 6 weeks, 10 weeks, 14 weeks for the 3 doses of doses DPT, then measles at 9 months. And then we are thinking of in the 2nd year of life, when we introduce the 2nd dose of MR and other things, maybe on the 2nd dose of measles, and maybe DPT is also being thought about. So that's how the life course cycle one, I would say, yeah. So it is something that is happening, and yeah.
And I'm also going to interrupt and just ask you one other question that's just come in about the use of registers and coverage, monitoring coverage. And I'll ask the same question about Samoa and Brazil. So there's the life course, and then and any concluding comment you make. But we do need to wind up. So, do you have an electronic register in Uganda, or what is the process you're moving towards?
At the moment, we don't have a well-established electronic registration, but this is something we are working on. Actually, even this morning we were discussing with Kampala State Council Authority to consider starting the registration system. We are starting by paper registration, but hopefully we shall move into the electronic-based registration, which the ideal should be using this registration system. We can be able to track each and every child, be accountable for each and every child, so that at least we can know default trace, using it to default trace and reach out to each and every child. So it is that accountability and reaching every child that the electronic registration is actually required. Yeah.
We look forward to that. Razel Bakarov.
Yes, thank you again for the opportunity. Samoa does have the electronic system, but it's not complete. It's just at the central level, but not at the peripheral level. So the work is, like in Uganda, it's ongoing to link that two systems together to create one. Yes, and I just want to say that, you know, I lost my mother due to cancer some time ago, and should HPV vaccine be available for her generation, she probably would be still alive. So I just want to say again that Samoa planning to introduce 4 new vaccines, and HPV is among them. Thank you very much.
Thank you so much. Professor Luis de Souza.
Yes, thank you. Yes, we do have a program for life course vaccination. Actually, for the elderly, the flu vaccination is a huge success, high levels of coverage. And we have a HPV also for school children at the 9 to 11 years old. And I think that they have not dropped in this coverage, have a good situation. And finally, I would like to thank you and congratulate the World Federation for this initiative.
And Professor Ricciardi, and you know, when I think of the life course, I also think of influenza, I think of varicella, and those vaccines for the elderly as well. And so, you know, the challenges are there in front of us. And just before I go to you, Professor Ricciardi, we are going to have to let 1 or 2 questions go, but there's also been some really nice comments thanking you and each of the panelists about particularly the information around vaccine hesitancy, but for the whole presentations. Professor Ricciardi.
Yeah, and I think it's very important to consider vaccination as a tool for the entire lifespan. But as we said before, covering and encouraging elderly people to be vaccinated is another story. And there is quite a lot of vaccine hesitancy also in that in those age groups. So we have to develop specific programs for them. And in particularly, I think that anti-pneumococcus and anti-influenza vaccination will be very important in the next autumn and winter, when we could have the recurrence of the coronavirus epidemic. So having that protected, of course, it makes a lot of difference, particularly to avoid the vast people coming to the accident and emergency department. Last but not least, I couldn't agree more with Rasul about the HPV. We have a vaccine which is very important, but we need to promote it mostly. It was not one of the 12 introduced in Italy as mandatory, because it's for adolescent girls, and we thought that has to be a free choice. But the coverage rate is not yet satisfactory. It's around 60%. So we have to work on that. And I think it's the next campaign, you know.
Thank you, each and every one of you, for your presentations and for being with us. I think that this has been really very helpful. And a particular thank you to the participants who joined us